I'm going to talk about knee ligament injuries today in the skeletally immature population with a focus on the ACL. It's what we see probably most commonly, and there's been a lot of research into it. So it should be interesting to think about and talk about. What I hope to cover today is a little bit of the background of the injury and the scope of the problem. I'll get into a little bit about some of the specific considerations of the immature knee when we're considering surgical options for reconstruction. Talk a little bit about the special challenges with rehab of these athletes, and go over a case. No disclosures. I'll start with a case from my practice. This is a 13-year-old and 1-month male, injured his left knee playing basketball. It was a non-contact injury, as is typical with these, where he planted and pivoted on it, and he felt a pop and immediate pain and noted swelling right away. He had no previous problems with this knee. He was otherwise healthy, and his social history was pertinent for being very active in sports year-round, basketball, baseball, soccer. A couple MRI slides here. On the slide to your right, we see a sagittal image through the knee with a complete proximal ACL disruption. You also see on both of these that the physes or growth plates are wide open. On the right here, you see that at least the portion of the meniscus there is intact. That's the lateral side, and you see a characteristic bone bruise pattern on the distal femoral condyle, along with a corresponding contact lesion on the posterior aspect of the lateral tibial plateau. Plain x-rays as well. You see a flexion weight-bearing view of the bilateral knees on your right side. Again, you see that the growth plates are wide open, normal alignment and rotational profile. You don't see any osteochondral injury. You don't see any avulsion pieces, which are things you want to look for in kids. It's important early on to also get a hand x-ray in any patient that you're considering operative intervention around a joint. And I'll get into this in a bit, but this is good for skeletal aging purposes. There's an atlas available where you can get a pretty good idea of how much growth is remaining based on the different growth plate closure characteristics in the hand. So to step back and make sure we're on the same page with a couple of terms, the physis is essentially another term for the growth plate. And the way long bones grow is most of the longitudinal growth occurs at the ends of the bones, so around the joint. The epiphysis, which I'll talk about, is basically the part of the bone that's between the growth plate and the joint. So the shorter part of the solid calcified bone that's adjacent to the joint. Metaphysis and diaphysis refers to the part of the bone that's away from the joint, so the shaft. And the earlier cell activity is near the epiphysis, and the growth and maturation of the cells occurs toward the shaft, so toward the metaphysis. For a lot of reasons, there's been a dramatic increase in pediatric sports participation over the last few decades, probably more than 20 years. And the most recent data I was able to find is that there's roughly 38 million youths that participate in sports yearly in the country. So obviously that's led to a lot of injuries, both overuse injuries like we've talked about so far, and traumatic injury. Most recent data that I saw showed about 2 million high school injuries requiring treatment from a physician, and clearly some of the high school athletes are skeletally mature. But even still, when you include pre-high school in this, less than 14 years old, there are about 4 million injuries requiring treatment. So this was before my time, but from what I hear and what I read, ACL injury in this population was thought to be a relatively rare occurrence. And we found that that really isn't the case, and young athletes certainly do injure their ACL relatively frequently. High school soccer players are actually notorious for this, and I think this is one of the most common groups of athletes to sustain an ACL injury, along with high school football players being a close second. We've looked at studies that have shown that with an acute hemarthrosis after a traumatic injury, a pre-adolescent patient is almost 50% likely to have an ACL tear, and an adolescent patient about 65%. So 2/3 of the time, when you see a 14-year-old soccer player with an acute injury with an effusion, you can say 2 times out of 3 they're probably going to have an ACL tear. So a little more background. So most of the growth in the leg occurs around the knee. A couple of assumptions. One is that in boys, growth occurs up until about 16 years old, and in girls a little earlier, stops around 14 years old. And obviously there's a range, but those are our averages. The leg in total grows about 23 millimeters per year, which is about an inch. And most of that, so about 2/3 of that, comes from around the knee when you combine the distal femoral physis and the proximal tibial physis. Proximal femur, so at the hip, only grows about an 1/8 inch per year. Distal femur, 3/8 inch. Proximal tibia, about 1/4 inch. And distal tibia, less than 1/4 inch. So what you can extrapolate from this, and if you consider a 12-year-old boy who may have 4 years of growth remaining, if you were to completely disrupt that growth at the distal femur, we're talking about 1.5 inches or so leg length discrepancy, which can certainly present a clinical problem. We talk about growth disturbance, and often this doesn't occur all the way across the physis. And when that happens, you actually get a tether on one side of the physis, which will lead to an angular deformity. And think about that as you look at this clinical picture here, which is not one of mine, but something that I was able to bring in. If there's a tether of the growth plate on the lateral side, on the outside, and an arrest of growth there, while the medial side continues to grow, that'll lead to an angular deformity. There's been a lot of thought about this, both as related to traumatic injuries around the physis, and then in looking at surgical intervention. And mostly in animal studies, they've done taken a look at this and found that if less than 5% of the cross-sectional area of the growth plate is disrupted, we don't worry too much about growth disturbance. Around 7 to 9%, you start to think about disturbance being possible, even if there's not bone across it, if it's just with a soft tissue graft like a hamstring that we often use. I think the scope of angular disturbance after ACL reconstruction is not huge. I think most of what we've seen on this really is small case series and case reports. But I think that it's something that we at least need to consider because the clinical consequence of a growth arrest can be considerable. So I'll get into some of these things that I mentioned here. But in a survey of very experienced knee surgeons, they noted about 15 remembered incidences of growth disturbance after an ACL reconstruction. And just anecdotally, what this group came up with was avoiding fixation across the physis, which makes sense from the tethering perspective. Avoiding large tunnels where we do more damage to the growth plate. Avoiding tenodesis, which is non-anatomic and not something that we really think too much about anyways. And then certainly avoiding dissection at the bone cortex around the area of the growth plate. This was just an MRI imaging study, actually just computer modeled representations of tunnels across a growth plate, and looking at about 8 millimeter tunnels in the size, a size range of 10 to 15-year-olds. It was found that less than 3% of the physeal cross-section area, so less than 3% of the growth plate, was disrupted. Based on that, you would think that it's okay just to drill across it if you combine that with our animal model studies. The problem with that is we're often not drilling straight across the growth plate, and especially with the recent emphasis on anatomic ACL reconstruction, we're often drilling obliquely across the growth plate. And if you think of it from a perspective of if you had a drill bit, a centimeter drill bit on your table, if you drill straight into the table, you have a 10 millimeter hole, right? If you drill obliquely, so if you turn your hand up 45 degrees, you have an oval that has an area greater than that. And if we're trying to get the ACL right in the anatomic footprint, needing to drill more horizontally, you can really scythe across the growth plate and certainly make a bigger hole than you think based on the size of your reamer. So because of that, I think we do need to think about it. Like Dr. G said, these slides were made a couple months ago, so bear with me. So historically, this was before my time and before my training. I think some people were hesitant to surgically stabilize a kid with an ACL injury. And we often talked about bracing, activity modification, waiting till closer to skeletal maturity before doing surgery with the concern of injuring the growth plate. However, we saw pretty clearly with that thought of treatment a high rate of recurrent instability and associated secondary injuries to the knee, especially the meniscus and the chondral surfaces. There's a pretty often cited cohort study, I think this was in the late 80s, looking at either operative or non-operative intervention in immature patients who had subjective instability, so feelings of the knee sliding around, and found a significantly increased rate of medial meniscus tears and lateral compartment chondral injuries in kids that were not treated surgically. And this was even with relative activity modification, taking it easy. But these kids who do have these secondary injuries certainly have a bigger problem than they did beforehand with just the ACL injury. Similarly, there was a large systematic review looking at outcomes with surgical versus non-surgical treatment in skeletal maturity ACL injury, and outcomes were clearly much better with regards to future stability, secondary injuries, and one thing that they make a point of in this study is that they didn't necessarily think that it made a huge difference what type of surgery was performed. It was just that the decision to stabilize the knee was important. So again, this is a bit out of order, but in general, pediatric knee injuries are a little bit difficult when compared to many adults. The physical exam can be very difficult due to apprehension, pain, and fear. Exam of the uninjured knee is often helpful first to create comfort with the patient and to demonstrate the maneuvers to expect on the injured knee. But in general, in my practice, and I think anywhere, any history of a traumatic knee injury causing an effusion should warrant consideration of an MRI. And I've certainly seen in the last year a few patients who come in, say they injured their knee playing soccer a couple months before, it swelled up, they iced it, took it easy, got back on the field, and the knee shifted on them again, and they come in with a bigger problem with obviously an ACL tear, but a meniscus injury as well. MRI is pretty sensitive in this population. I think this was an old number, and I think with the imaging coils getting better, greater than 95% sensitivity for ACL injury. There's a fairly broad differential diagnosis for an acute effusion in a kid, the big ones being ACL injury and patellar instability. Certainly also need to consider fracture involving the growth plate. Meniscus injury, isolated chondral injury, certainly things that we'd want to see on an MRI anyways. So I just get an MRI anytime there's an athlete who injures their knee in this age population and swells up. So at least historically, non-surgical treatment was thought to be reasonable until closer to the time of growth plate closure. In a few well-selected patients, so in the low-demand, highly compliant patient. But typically a kid who is doing something to tear his ACL will want to go back to that activity, whatever that activity was that caused them to tear their ACL. And this patient population is notoriously non-compliant with activity restrictions. So I think most people, and I certainly do, recommend surgical stabilization in most cases. Fortunately, the majority of ACL injuries before skeletal maturity occur in 15, 16-year-olds who are getting pretty close to being mature adults. And that makes things easier from a technical perspective in that we can pretty much treat them as we do adults with anatomic ACL reconstruction. I think the one thing that I would do differently is not consider a patellar graft. We're using bone plugs across the physes in anybody that's not skeletally mature. But hamstring is an easy alternative to that, and you avoid a bone block across those tunnels or across those physes. When we start to talk about younger kids, so pre-adolescents and early adolescents, surgical management is the subject of more debate. I think there's a lot of right ways to do things, but I think as long as you think about it and try to at least think about limiting the injury to the physis, it's worthwhile. So as we talked about a little bit before, in my practice, for skeletal age determination, I use a hand x-ray. You'll hear a little bit about Tanner staging and looking at secondary sex characteristics to get some idea of the amount of growth remaining. But at least in my practice, I think it's easy to get a hand x-ray. There's an axis or an atlas, the pile atlas, that you're able to compare any hand x-ray to and get a pretty good idea of how much growth a kid has remaining. So to get into a little bit about surgical options, first talking about the littlest kids, so pre-adolescent. This is more just for information. Min Coker has a technique that's been pretty well popularized. I'm not sure many people do it other than him, but it's good to think about at least from a perspective of principles and trying to not injure the growth plate. So he talks about a lateral extra-articular reconstruction where you actually take a band off of the IT band, sling it around the lateral femoral condyle, and attach it somewhere in the region of the native tibial ACL insertion. And he had a large series of this, reported really good results with it. And I do think it's a valid consideration. People, again, I think more historically talk about transtibial, so going across the tibial physis, but fixing the femoral side in what's called an over-the-top position, whereby the femoral side is slung around the lateral femoral condyle and fixed to the lateral side of the cortex without going through the physis. And it's semi-anatomic, and people reported pretty good results with it, so I think it's something reasonable to keep in mind, but again, I think probably more of historical significance at this point. There's been some interest more recently in fixation all within the epiphysis, so nothing crossing the growth plates. And I think this is a very reasonable option, especially in very young kids, pre-adolescent, you get into your 9, 10-year-olds who have a lot of growth remaining around the knee. There was a pretty good mechanical robot comparison of those 3 techniques for reconstruction in very young kids, and on a robot they were able to assess rotational and translational profiles at different knee flexion angles of those 3 reconstruction techniques, so the all epiphyseal, transtibial over the top, and the IT band method, and they all showed restoration of pretty normal knee kinematics and even over restraint with the IT band method at some flexion angles. And that's, I think, consistent with the clinical reports of these methods, both all being pretty good. When we get into early adolescence, so your 13, 14-year-old males with relatively little growth remaining, I think the objective is to provide as anatomic and ACL reconstruction as possible while limiting the potential for injury to the growth plate. And we do have a few options in this regard. Certainly we want to think about smaller tunnels when possible. Now, I certainly don't trim down my hamstring grafts. I think having a good sturdy graft is important, but typically we're talking about an 8 or so millimeter graft, which is reasonable. We think about, when possible, more vertical tunnels, especially across the tibial physis, and that's easily done technically without really having to change anything much. We certainly want to think about metaphyseal fixation, so nothing across the growth plate. And again, this isn't my picture here, but this would obviously be a bad idea to put a metal screw across the tibial growth plate in a still growing child. So the differences are subtle when you talk about early and into late adolescence. And I think these state the same points as the last slide. I think a very valid option, especially for younger adolescents of 12, 13 into 14-year-olds, is a hybrid technique where you're drilling across the tibial physis with small vertical tunnels, not fixing across that growth plate, and then keeping the femoral tunnel and femoral fixation all epiphyseal, so all within the area of the bone distal to the growth plate. When we get into older adolescents, so nearing skeletal maturity, getting on 16 years old for males, 14 for females, I think the bottom line is we're probably pretty safe to do whatever we want as far as an anatomic ACL reconstruction. I think even in this group, putting a bone block across the growth plate is probably unlikely to really pose any morbidity. But I think that knowing what we do about ACL grafts with hamstrings doing pretty well, I think there's really no reason to put a growth plate or put a bone block across the growth plate, especially when you hear about kids who get into college and can grow several inches. So you never really know, and I do feel safer that way. So looking at a little bit of the evidence for reconstruction in this population, post-op MRIs performed in a group of 43 patients. That was a little bit older, so almost 15-year-old kids showed that the average tunnel was less than 3% of the physis, which is consistent with the computer model that I talked about before. This was a little bit ago, so this was pre anatomic ACL reconstruction range, so that may have an impact on this. But they did show in this study 5 patients with MRI findings of focal physeal injury, so a small bar across the growth plate. And despite that, they didn't show a clinically apparent growth disturbance. But again, that was an older patient population with little growth remaining. Partial transphyseal, so across the tibial physis, while sparing the femoral physis, has shown good outcomes as well. A little younger age group, so 13-year-old on average at 3 years, they showed 80% back to full activity. They did show one patient with a 2 centimeter leg length discrepancy, and presumably this was due to technical error where they were actually in the femoral physis unintentionally. One more similar study, partial transphyseal, so through the tibial physis, over the top, so avoiding the femoral physis, with all allografts. And this is my plug for using autografts, especially in this population. I found significant laxity in 38%, but no leg length discrepancies. So getting on to older kids, so almost 15 years old, approaching skeletal maturity but not there yet, transphyseal complete ACL reconstructions with hamstring autografts and metaphyseal fixation. Good results, 2 graft failures, no leg length discrepancies. So again, this is my I don't want to call it evil, but I'm not a big fan of allograft, and I think especially in this patient population, it's an extra bad idea. Patients 10 to 19 on their own have the highest re-tear rate with ACL reconstruction, and it's much higher than that with allograft. And one study showed a 4-time higher risk. There are other studies showing even higher rates than that. Complications, so we talked about it a little bit. Growth disturbance, actually relatively rare, but something that we may make more of than we need to. Re-injury, however, in this population is relatively common, both based on patient return to play expectations and some degree of noncompliance in this population. Post-op management can be challenging, and this is often where the therapist is very helpful. Therapists with PEDS interest or PEDS experience can be very helpful in managing these kids. Compliance monitoring is essential, so parents, therapists, coaches, anybody who's involved, because after reconstructing a kid, they'll be feeling pretty good in 3 months, and they're not ready to get back to things yet. So constant reminding of things they are and are not able to do is important. Bracing typically recommended, but similar to the adult population, I don't know of any true evidence-based guidelines that support this, but I think it's the standard of what most people do. And in this population, and similar to adults, I tell them return to play no sooner than 6 months post-op. Returning to case example. just over 13-year-old, non-contact ACL injury, kind of early to mid-adolescent, 10 or 3 minus, with a skeletal age similar to the chronologic age. I did a partial transphyseal reconstruction, so drilled across the tibial growth plate, which you can see here, and this is actually my scope in the tibial tunnel. You see the physis right here, and I'm drilling straight across it, so with a long vertical tunnel. And on the femoral side, drilling from the outside in with what's called a flip cutter device, where I'm completely within the epiphysis. And we see that it's helped with fluoroscopic intraop assistance. Drilling my tibial tunnel, you see the growth, my femoral tunnel, I see the growth plate here, my reaming device here, and again on the lateral, my entry point at the ACL footprint, safely away from the femoral physis, and my fixation on the cortex with a suspension device. Tibial fixation here was actually with an interference screw, but looking up the tunnel, I'm able to measure the distance from the tibial cortex to the growth plate, and as long as you keep the screw shorter than that, you're not going across it. The kid did well. Returned to play about 8 months post-op. Most recent follow-up was about 18 months post-op, and he was asymptomatic, had forgotten about it. He was still growing, but had no leg length and no angular asymmetry. Takeaways, most ACL ruptures in this population should be given at least consideration for operative management. These are certainly not hard and fast rules. I think, though, in the prepubescent population, you want to consider physeal sparing or at least partial physeal sparing. I think in adolescents, consider transphyseal reconstruction with hamstring graft, small vertical tunnels, and metaphyseal fixation, or partial transphyseal, avoiding the femoral growth plate. And then when we start to get into closing physes, so nearing skeletal maturity, talk about anatomic type ACL, anatomic type adult ACL reconstructions, just limiting bone blocks across the physes.